For this year at SIOG, we have multidisciplinary cancer sessions in which we discussed interesting cases for each specific tumor type. And we had a breast multidisciplinary cancer session in which we discussed two interesting cases of uncommon types of cancer in older adults. There's this idea that older women, all of them have hormone receptor positive breast cancer, but quite a large proportion of older patients have HER2 positive or triple negative disease. So in our discussion yesterday, we presented one case with HER2 positive disease and one case with triple negative disease, and we went over treatment options with a multidisciplinary team of surgeons, radiation oncologists, and medical oncologists. Well, I think there is a huge need to increase the evidence base for treating older patients with triple negative and HER2 positive disease. As you know, older patients are often excluded from clinical trials, and the proportion of patients aged 70 or older, and even more so for patients aged 80 or older in clinical trials of new drugs in breast cancer is very low. So the information that we are using to treat these patients is mostly extrapolated from a younger population or from very fit older patients. So I do think that finding those gaps is important for future research and for increasing our knowledge about how to treat this population. And one of the things that we discussed and that is very important is tailoring the treatment to the geriatric assessment and to the general situation of the patient. Sometimes we as oncologists are very focused on increasing survival, and this may not be the most important outcome for our patients. And sometimes the life expectancy of our patients may be very limited for other causes, or they may have competing causes of mortality, and increasing our treatment may just cause more burden without actually giving benefits for patients. Well, I think that there are many challenges for treating older patients, but more than challenges, I think we should view it as opportunities. Because as we keep finding other issues that may impact the outcome of treatment, we also need to figure out how to intervene on these issues and improve them. So I already mentioned cognition, but also taking into account social support. So one of the things we discussed was utilizing different radiotherapy schedules so that it's easier for patients to complete treatment. During the session, it was mentioned that a lot of patients live far away from treatment centers, and going for radiotherapy for 5 weeks may be a problem, particularly for patients with poor social support. So using shorter radiotherapy schedules is one of the solutions, and it's something that is being used across the world now with older patients. And also decreasing the burden of chemotherapy administration is something that could be done in patients with poor social support, for example. I think that the take-home message from our session is that there is a lack of information in treating older patients, and that we must individualize and use the geriatric assessment and other things that are going on with our patients in order to select the best treatment that aligns with patients' needs and with patient priorities, causes the least harm possible, and gives patients a significant life expectancy and, most of all, a high quality of life.